Hi, today I'm gonna be doing an ear and eyes assessment. So, before we begin doing anything, we want to make sure that we introduce ourselves. We provide patients privacy. We provide patients with all the information, like what we're here for, what we're gonna be doing with them. Then we perform hand hygiene. Then, in my case, I'm gonna start with the eyes assessment. So, Um, for the eyes assessment, um, I'm gonna need to check the patient's eyes for symmetry, if they're equal, the way they're positioned, are the eyes sitting normally in the eye socket. Um, does the patient have any jaundice, any eyelid swelling, any strabismus, any anisocoria, or anything like that, anything abnormal that you could see in the eyes. Then I want to use a Snellen chart to check the patient's far vision, and a Rosenbaum Jesus chart to check for the patient's near vision, and an Ishihara test to check for color vision. So after doing that, we want to make sure that we assess the patient's eyes for the cranial nerves, three, which is oculomotor, cranial nerve 4, which is trochlear, and cranial nerve 6, which is abducens. So what we're gonna have the patient doing is um, first of all, we have to check for the patient's eyes for any involuntary movement, um, otherwise called nystagmus. And to do that, we hold the pen light um, for about 12 to 14 inches away from the patient's nose. Then we have the patient follow the pen light to the cardinal positions of gaze. Just the eyes of the patient have to be moving, like following the pen light. They're not allowed to move their head for any of those movement. And we check the patient's ability to we check the patient's eyes for perla. We have to make sure that the pupils are equal round and reactive to light and accommodation. To check if the pupils are equal, we basically shine the pen light to the patient's eyes. The pupil have to be constricted for about 3 to 5 centimeter and diameter. That's the normal range. And the way we check for the patient's eyes accommodation, we basically have the pen light to the patient's nose. Then we kind of have the patient follow the pen light direction, like you take the pen light off the nose and back, and that patient literally have to just follow the pen light. So that's how you check for the patient's eyes accommodation. So that will complete the eyes assessment, and after every assessment you want to make sure that you document everything. Then I'm gonna move to the ears. So the way we do an ear, the ears assessment, we start by looking at the ears for symmetry. The position of the ears have to be like parallel to um, the eyes, and then we start by doing a whispering test. We stand for about 1 feet or two away from the patient, like from the back. That way, the patient is not able to like read your lips for whatever you're gonna say to them, so they have to repeat back. So it's better if you stand behind them. So you just whisper something by occluding one side of the ear, so they have to repeat back whatever you said to them. Then next, we do a Rene and Weber test, to check for the patient's conductive hearing loss and sensory neural hearing loss. To do the Rene test, we basically just take a tuning fork, we cling it somewhere. We're just looking for that fork to vibrate. Then we place it on the mastoid bone behind the ear, and then we ask the patient to let us know when they stop hearing the vibration. Then we move it to the front of the ear. By the way, we have to make sure that we do it for both ears, for both sides. And we place it in front of the ear, and then we ask the patient if they're still hearing the vibration. If they do, so that's a normal finding. The air conduction should be greater than the bone conduction, so that's a normal result. And then we move on to do the Weber test, which we basically do the same thing. We get a tuning fork, we cling it, then we place it on top of the patient's head, and we're expecting the patient to be hearing the vibration from both sides. That's a normal finding. If they do, that's normal. If they don't, so they have some type of sensory neural hearing loss. Lastly, we wanna check the inside of the patient's ear. We use an otoscope for that. Then we insert it inside of the ear for about 1 to 1.5 inches. Is it inches or centimeter? I don't really remember. So we're looking for a pearly gray looking tympanic membrane, and then we're looking for light reflex in there, and it should have a cone shape, and you should see the light at 5 o'clock in the right ear and at 7 o'clock on the left ear. Any other position of the light and any other shape of the light is sign of some type of issues in the ear. And just FYI, if you're dealing with an older patient, the tympanic membrane will be thicker than a normal average person's ear tympanic membrane. So, and at the end, you want to make sure that you document everything. So that's basically that's all for my ear and eyes assessment. Thank you.